In the OPD, with respect to the pre-pregnancy workup and in the process of giving the clearance, apart from the nephro-related part, few questions a patient might be having. Sir, in the thyroid report, I was on a particular dose of thyroid replacement, and because of this pregnancy, they have increased my dose level. What could be the reason? This is one. Another one with respect to the normal range of TSH. Especially a pregnant female might be having apprehension with related to that, whether it is normal or not. So the topic for discussion is related to that, which is thyroid and pregnancy. We'll see 5 important facts related to that. Thyroid hormone is very important for the fetus as such. It is important for the adult function also. For the fetus development, it is very, very important. The fetus will start producing thyroid, or the thyroid development completes around approximately 12 to 14 weeks from the second trimester, and on average it takes 12 to 14 weeks. Till that time, the only source of thyroid hormone which is important for most aspect of development is through the maternal thyroid. So the maternal thyroid is very important for the fetus well-being and growth. Why the TSH cutoff, or what are all the changes overall which occur during pregnancy? What are the changes which occur which compared to the normal patient or a normal person? In pregnancy, the homeostasis of the thyroid milieu changes. Why? There are multiple reasons, important of which is increase in the thyroid binding globulin, the HCG hormone which is being secreted during pregnancy, almost having a somewhat mimicking effect similar to TSH. Thereby it stimulates the free T3 and free T4, thereby the actual TSH level goes bit low. Somewhat similar structure, thereby it have a similar role to TSH. HCG increases in pregnancy. It has a similar, approximately similar, not going into the technicality of what is the amino acid level and all. Just you can remember the HCG increases, TSH level bit comes down, and also placenta is having some kind of deiodinase activity, overall dilutional effect in the body. All this leads to some kind of homeostasis derangement. We can't say it as abnormality, derangement, homeostasis alteration. Why? Very important for that particular homeostasis milieu is important for the fetus to grow well. So this is the reason why the TSH bit goes low. Then coming to the next one, why this thyroid hormone important we have seen. What will happen if the thyroid is bit low? It has both maternal and fetal related effects. Maternal is mother, and the fetus related effect. So rather than discussing if the hormone is low, the complications are there for maternal mother and the baby, we can put it in simple terms. If the thyroid is good, the outcome will be good. The mother will be saved, the growth will be good. So growth will be good if thyroid hormone is good. If thyroid is bit on the lower side, a most common issue might be the BP might be elevated in the mother, the growth might be hampered in the fetus. Apart from that, no need to discuss regarding the particular what complication have happened, because during pregnancy just listen to the good stuff. If this thyroid is normal, fetus is going to have a good growth. Then coming to the fourth one, what is that TSH cutoff? Thyroid stimulating hormone level cutoff. In pregnancy, almost all the institute following the protocol, thyroid will be checked at the earliest. Suppose if a female is already on thyroid replacement, again during the conception period before planning the pregnancy only, the doctor might have advised regarding the thyroid function test to make sure free T3, free T4 and TSH are in the normal range. Suppose if there is no past history, even if there is a family history or history of goiter or neck swelling, then also the initial screening is recommended. And currently most of the hospital, almost all the hospitals are getting the thyroid function test, at least TSH in the first trimester or as soon as the pregnancy is confirmed. So the TSH targets varies with the trimester level. The most important phase of the development is the first trimester. During that time, TSH preferably less than 2.5. The lab reference range for the particular trimester range can vary from lab to lab, but overall if we take the broad guideline, it is less than 2.5 milli international unit. Okay, this is the cutoff. Many a times, because of the increased HCG and T3, T4, most of the time it comes in the 1 to 1.5 range only. Lab specific, trimester specific cutoff. There are some periphery or in the third tier cities where a lab might not mention the reference range, just they might mention the reference range for an adult female not considering the pregnancy. During that time, TSH level might be mentioned as normal is less than 5. During this time, a pregnant female might be having confusion. My value is 4. Why the doctor is starting me on L-troxin? Because during pregnancy, that cutoff is different. You might have got the cutoff which is for the adult, not for the pregnant level. So that is the answer for the initial question that we have discussed. A cutoff for pregnancy is different. During pregnancy is different, in the adult population is different, and we have seen why it is. What is the replacement? As soon as the hypothyroidism is detected, suppose if TSH is high more than 2.5, a treatment have to be started after the physician, if endocrinologist available, well and good, after the opinion, so that baby will grow better. So first we have seen what is the normal cutoff, trimester wise varies, that we have seen. The last one, what is the replacement? Ideally if we take, the replacement is approximately 1.6 microgram per kg, what we see in the normal thyroid replacement. Whereas in during pregnancy, it might be go up to 2 to 2.4 microgram per kg. The replacement will be on bit higher side, per kg basis as per the patient pregnant female weight we have to decide. And suppose if a pregnant female was already on thyroid medication, the physician or the endocrinologist might increase the dose by 20 to 30%, because during pregnancy the dose increment is required because of the need, the basic metabolic need is there. That is why the dose escalation might be there. The dose escalation is based on the TSH level. Okay. So once the treatment is started, this we have seen. So once the treatment is started, it usually we have to follow it every 6 weeks. The TSH level might be followed at a period of 4 to 6 weeks, ideally at the 6th week. The target have to be achieved. So this is all regarding the TSH level or thyroid, and 5 important facts related to pregnancy, and 2 common questions that we encounter in the OPD. Why, despite my thyroid level being 4, why thyroid is started? Because of this reason. Once the pregnancy baby is delivered normally and healthy, subsequently in the post-pregnancy period, TSH level will be checked. If it is coming back to the normal, the drug will be stopped. Okay. After making sure free T3, free T4, anti-TPO antibody is negative, then it will be solved. And one more question, 2.5 is the cutoff. Suppose if the value comes exactly at 2.5, what to do? Anti-TPO antibody to be checked. Anti-TPO, thyroid peroxidase antibody to be checked. If it is positive, probably the person might be started on L-troxin. These are subtle technical related stuff that the treating physician will take care of. So that's all, 5 important facts regarding pregnancy and thyroid. Bye-bye.